Hello and welcome to today's video. Hope you enjoyed the opening sequence. As you can see, I've bought myself a few new toys in the hopes of making the audio quality slightly better and also creating a bit more visually engaging content for some of my videos. I'm still very much a novice at learning how to make these YouTube videos and a single content creator, so I'm doing all the editing myself. So I hope my audience can bear with me while I learn to polish and refine the videos in the future. Today, I want to talk about the ESR conference, which I had the privilege of presenting at in Abu Dhabi just a few days back. Now, if there are patients watching, the topic is relatively medical, but you still might be interested. Before I share the debate that I participated in, I thought I'd share a few reflections on points that stood out to me from the conference. I won't be individually naming all the presenters. What I will do is put a little link up on this video for where anyone might wish to view the actual program of activities. So it was a 3-day conference. The first day was focused mainly on vasculitis. It was really useful to get an update on the treatments that are working and perhaps those that we've learned more about, when to consider cyclophosphamide or rituximab, and in particular the role of things like plasma exchange, which is not really something that has a strong role in most forms of vasculitis, really being confined to things like good pastures and possibly in the situations like cryoglobulinemia or really advanced kidney injury, but for the most part doesn't seem to be hugely helpful and may increase risks, for example, risks of infection. The other was talking about steroids, with data presented showing that actually if we're giving IV steroids or intravenous steroids, there's no real difference in flare rates or response, but the intravenous steroids are tending to give more consequences like severe infections and consequences down the line like diabetes with a higher cumulative dose. So really, if you're absorbing steroids from the gut, no need to resort to intravenous steroids in the majority of cases. We also discussed rituximab and whether you should be giving that on an on-demand basis or a fixed schedule basis, with a general consensus that for around 18 months you do this on a fixed basis and then moving to an on-demand basis unless there's flares, in which case you might extend the regular regimen for perhaps 24 to 48 months. And finally, some discussions on the new C5a inhibitor, avacopan, which is showing in particular it has a good role where there's kidney proteinuric vasculitis and also skin involvement. My thoughts from day 2 started with an interesting talk on artificial intelligence, with some of the roles for artificial intelligence in assisting diagnosis, a slightly more upbeat prediction that doctors will utilize artificial intelligence without being replaced by it. Personally, I think we may be at bigger risk of losing our jobs to artificial intelligence down the line. There was also some really fascinating discussions on CAR T therapy. Rheumatologists will know what this is, but if there are patients who are not sure about this, this is a really interesting novel therapy. There are some claims about it being curative. We don't know if that's likely to be the case, but certainly there's been some dramatic improvements by engineering specific type of T cells to basically target whatever effector cell you want to target. So in the case of many of our conditions, targeting B cells via CD19 receptors. I was really also fascinated to hear that we're doing CAR T therapy in the UAE at Yas Clinic in Abu Dhabi. So that's a really exciting development to know that we've got somewhere locally where this really advanced therapy is taking place. There were discussion on SGLT1 drugs, which are more commonly known as the weight loss drugs, things like Manjaro. We obviously know that these are good for sugar control, weight loss, but through this, they also likely have some anti-inflammatory effects. We do know that certain types of fat, like visceral fat, is not an inactive tissue, is metabolically active and may be driving inflammation. Not only that, but obviously if you have reduced fat, it might help with dosing of drugs because you may need less drugs to be effective. But there are risks, especially if you don't give these medications with good dietary support, particularly if you also don't maintain your muscle mass, because if you lose mainly weight from muscle mass, you can effectively be thin fat. So you can effectively maintain a poor ratio between your fat tissue and your muscle tissue. Despite the fact you've actually lost a lot of weight, you've been losing it from muscle, and that leads to sarcopenia, which increases risk of things like falls and reduced mobility. There was a good discussion on the overview of JAK inhibitors and how they fit in, because these drugs are proving to be incredibly useful across the spectrum of rheumatic diseases, and a reminder that because of the selectivity of these JAK drugs to the specific subunits, they have different effects on different cytokines, which means that they're not really as similar as, say, different biologics within the same class. There was an impassioned talk about antiphospholipid syndrome and the novel classification criteria, in particular the pitfalls of this criteria, in the fact that it may under-recognize a number of patients, and therefore we may lead to reduced pickup rates for patients suffering antiphospholipid. And a discussion on how to manage lupus, which we know is one of the diseases that can flare during pregnancy, in a safe manner, including things like when to time cyclophosphamide and rituximab. And on the third day, there were some great talks on osteoporosis, particularly looking into male osteoporosis, which we don't often consider when we're looking at osteoporosis as a whole, despite the fact that male osteoporosis has a higher mortality when there's fractures, fragility fractures, in particular looking at how to investigate secondary causes, and then a discussion on sequential therapy and how to best benefit by the anabolic agents, stacking them later with an anti-resorptive to get the best benefits locked in. There were discussions on Sjogren's and management of sicker features from dry eyes and dry mouth, as well as an overview of the new biologic that's likely to be coming online soon, a review of the EULAR guidance in Still's disease, and a discussion on biologics to choose for specific types of rheumatic interstitial lung disease. All far too much to go into much detail. Each and every one of those topics would easily fit the contents of one of my videos, and maybe I might expand on some of these. But I wanted to just introduce this before moving on to showing the debate that I took place in on the management of hyper-uracaemia. I hope you find it entertaining. It's a bit light-hearted. Again, I want to extend my thanks to the ESR committee members for inviting me to engage in this debate, but also a thanks to my brother who helped make the video that's a humorous video in the debate, which is called the Minority Lab Report. So I hope you enjoy the debate.
Ladies and gentlemen, welcome back. We will now proceed with Session 8, Metabolic Diseases, portrayed by Dr. Ahlam al-Martoubi and Dr. Tariq Akram. Please welcome them to the stage.
Assalamu alaikum, everyone. Thank you for the people who have stayed. I know it was a long 3 days. This is our last day, and hopefully, inshallah, we end up with a great month. We will have a debate. So I want everyone to be awake. I know we had just now a lovely lunch, but I think we can manage focusing on the great debate now. So we will be moderating the session, myself and Dr. Tariq Aslam. And inshallah, bi'ibnillah, we will have the best debate ever, and we'll see whether shall we treat or not to treat people with asymptomatic hyperuricemia. So I have the great honor to present both our speakers. We'll start with Dr. Elhadi Abbas. Dr. Abbas is a senior physician, over 30 years of experience across Saudi Arabia, Sudan, UK, and UAE. He has established the renal unit in major hospital and has a strong interest in the community health and disease prevention. And our second debater, Dr. Francis Houston, a British consultant hematologist at clinic, Parkview Hospital in Dubai, specializing in inflammatory diseases such as rheumatoid arthritis, psoriatic arthritis, gout, and ileal spondyloarthritis, as well as non-inflammatory conditions like fibromyalgia and osteoarthritis to hypermobility. So without further ado, I will leave the mic to the great debaters with me who will win this debate. Thank you so much.
Well, let me start by thanking the organizer, for giving me this opportunity to be part of this important meeting. And thank you who stayed late, okay, to listen to us. And I hope you don't regret staying late. Well, I'm going to speak about hyperuricemia chronic kidney disease. Do we treat or not to treat? Personally, I have been given, I've been asked to be the devil advocate, because I'm going to speak about to treat. We know, you know, and I know that most guidelines, well, they say don't treat asymptomatic hyperuricemia. I'll try to convince you to treat, right? And I had to say before that, okay, I always loved to be a rheumatologist, but I ended being a nephrologist. I went to UK from my country, hoping to be a gastroenterologist. I went to Sheffield, and there I was in a professorial unit where they had nephrology, gastroenterology, pulmonology, and oncology. And there were a few rheumatologists in my kind, even in the UK. And then the registrar in nephrology was taken sick. So I was asked to take his job for a month, become a registrar in nephrology for a month. So I did that, and then I continued doing nephrology. While I was doing that, an uncle of mine came to visit me. He was a professor of agriculture back home. He said, "What are you doing, my son?" I said, "Well, I'm doing nephrology." And then he looked at me like that and said, "Well, why do you do nephrology? Nephrology is a disease of poor people. You should have done rheumatology or cardiology. Those are diseases of rich people. Then you become rich." Well, his hypothesis was very true to me. I never became rich. But I hope you became rich being rheumatologist. Well, it's not moving. Okay. I do that right? Okay. I don't have any conflict of interest with this talk, and this will also be my agenda. Definition of asymptomatic hyperuricemia, prevalence of hyperuricemia, this one. Prevalence of hyperuricemia, gout and CKD, renal handling of urate during hyperuricemia and chronic kidney disease. Those three parts I will take maybe in the first 8 to 10 minutes. And then I will stop. My partner, Dr. Francis, will come over. And then after that, I will come to speak about evidence of the impact of hyperuricemia on renal disease and cardiovascular disease in general. And then I will finish with data from interventional trials of urate lowering medication in CKD. Well, asymptomatic hyperuricemia has been defined as elevated uric acid in the absence of monosodium urate phosphate deposition disease. And by that, we mean gout, uric acid nephrolithiasis, and urate nephropathy. When you have hyperuricemia without those things, you call it asymptomatic hyperuricemia. Those patients with asymptomatic hyperuricemia, most of them remain asymptomatic for life. About 2/3 of them remain asymptomatic. About 1/3 will develop symptoms, depending on the duration of hyperuricemia and the level of hyperuricemia you see. People with uric acid above 9 milligrams per deciliter, about 20% of them will have symptomatic hyperuricemia within 5 years. So a few of them will have symptomatic hyperuricemia. And again, we knew that hyperuricemia is very common. We don't do it, usually routinely when we see our patients. But if you do your tests routinely, you'll find that associated with hypertension, cardiovascular diseases, chronic kidney disease, and metabolic syndrome, including diabetes and obesity. If you want a numerical definition, it is anything above 7 milligrams per deciliter in males and 6 milligrams per deciliter in females. And you can see the international units in between two brackets. If you get levels above 8 milligrams, that's when you warrant to have the evaluation in asymptomatic hyperuricemia. Evaluation, we mean a thorough history. You ask about family history. You ask about drugs, because we know that there are certain drugs which can increase your uric acid. Okay. You ask about familial history of hyperuricemia as well. You ask about, those associated diseases, hypertension, cardiovascular disease, chronic kidney disease. And then you have to evaluate the patient by, doing at least some tests. A CBC to look for lymphoproliferative multiple disorders, renal function test, and you may be doing your urine excretion of urate, fraction excretion of uric acid. Since hyperuricemia generally is very prevalent, about 25% Chinese in Taiwan have got hyperuricemia. In the United States, about 20-25% in males and lower in females. We know that uric acid levels would be low in children, which are males or females. And then at puberty, it goes high and is stabilized at that level. Females will usually have low uric acid levels till they reach the menopause, when they have levels equivalent to males. What about gout? Gout is about 3.9% in the United States, 5.9% in males, and 2% in females. Do we know the prevalence of gout in the UAE? Any offers from studies, guesses, predictions? Anyone knows? Well, it seems you don't know really. I just looked into literature and found one study in a primary care setting where they looked at only Emirates, and the prevalence was only 0.1%. If you speak about the Gulf states, it was 0.51%. So those are very low levels compared to the West and the US. The reasons, I can't discuss it now, but I have some ideas why could have that been. What about CKD? CKD again is very prevalent worldwide. About 10% of the world population has got CKD. About 850 million people worldwide have got chronic kidney disease. And by 2040, CKD will be the fifth cause of death worldwide. In 2017, it's the 12th cause of death. So now it's increasing as a cause of death, and we know mainly the cause of death in CKD will be cardiovascular disease. And the other thing that, as I told you before, hyperuricemia is very common in diseases which can cause CKD, like hypertension, diabetes, obesity, and heart disease. Uric acid is maintained in the body by two factors, production and elimination. The production could be endogenous or exogenous from what we take, the urine intake we take. The endogenous production is seen to be about 70% or two-thirds of our uric acid pool in the body. So what we eat is about 30%. And that's why we need medication to lower uric acid, because we depend on lifestyle only. You want to get your uric acid level, wouldn't be able to do that. Elimination is through either the kidneys or the GI tract. The kidney takes the main brunt, about 70% of excretion, and the GIT tract about 30%. And then you'll be left with the uric acid pool in your body, 800 milligrams to 1,500 milligrams in males, 500 milligrams, 1,000 milligrams in females. And this is how is uric acid handled in the kidneys. In normal people, you get glomerular filtration rates, so 100% of your uric acid will be filtered. Out of that, only 2% will be absorbed initially, and then you get a secretion, about 50% of that back into the lumen, and then you will get reabsorption about 8 to 12% only. So the secretion of uric acid, about 90% of the uric acid pool which is filtered. In disease, there is inhibition of tubular reabsorption and enhancement of tubular secretion. So you get hyperuricemia. Well, those are the diseases which I spoke about, Gouty arthritis, tophi, uric acid nephrolithiasis, caused by crystal deposition. The other diseases which are due to soluble uric acid, cardiovascular disease, hypertension, chronic kidney disease, obesity, diabetes. And if you remember, always we thought uric acid is a passive bystander. It's just there, doesn't cause anything. Well, this is the pathophysiology of hyperuricemia, what it does. There are so many mechanisms of hyperuricemia here. RAS activation, increase oxidative stress, mitochondrial dysfunction, endothelial dysfunction, going to two phenotypes, either renal disease or other non-renal phenotypes. Renal disease would be glomerulosclerosis, interstitial nephritis, and chronic kidney disease, and maybe acute kidney injury in certain conditions. The non-renal phenotypes are metabolic syndrome, hypertension, cardiovascular disease, and others. Well, I think I'm going to stop here and then give it to Francis.
Thank you. Alaikum, and thank you very much for the invitation. It's a real honor to be talking here at the ESR, and I'm very grateful for the invitation, and I think the organizers can be incredibly proud of a really engaging and entertaining as well as educational conference. And I'm going to be in the spirit of I'm going to try and entertain you since we are post-lunch on the last day. So I will be presenting the easier argument, and I hope you don't take everything too seriously as I poke a bit of fun. Those are the last nice words before I start becoming a bit of a nasty person in attacking my opponent's position. So firstly, my disclosures, and as I'm not advocating for any treatment, you know that these are definitely no conflict. I'm advocating for best practice in looking after people with non-pharmaceutical interventions. Let me just, if I will, give you a glimpse into the future. This is a short film of the future in a world where we're treating asymptomatic hyper-uracemia, and I call this the Minority Lab Report.
In 2026, the future of medicine changed forever. A world where gout is stopped before it even begins. Introducing the Minority Lab Report, a breakthrough system that predicts gout attacks days before they strike. A flare next Thursday at 3 p.m. The lab already knows, and treatment is on its way. For 3 years, not a single flare has escaped the system. Perfect, precise, unquestioned. But doubts are rising about treating people who feel perfectly healthy, about predictions that may never come true. And when the system forecasts a gout attack for one of its own, everything begins to unravel. Still, one promise remains. We can end gout completely. All we need is your full treatment compliance. As doubt spreads, trust fractures, and the line between prevention and paranoia begins to blur. The Minority Lab Report, where prevention begins before disease.
A bit of fun, really, but I'm sure we don't want to be living in a world where we're all being hounded to take medications for a condition that may never reveal any particular consequences. So let me just move on to my next slide, if I can. So we all know as clinicians that association is not the same as causation. Coffee drinkers, for example, have associated higher uric acid levels, but I don't see us advocating for decaffeinated coffee across all coffee shops in the world. Likewise, there are associations between higher serum uric acid levels and high levels of cognitive function through a systematic review and meta-analysis. So I'm hoping we're not advocating to dumb down the population by reducing our serum uric acid concentration. I will add, by the way, that this study has been refuted in multiple other studies, but the point being, we have published literature that could support the position of treating asymptomatic hyperuricemia. So let us start with the guidelines which I'm most familiar with from my practice, obviously having practiced in the UK before moving to the Emirates. I'm going to start in chronological order with the EULAR guideline in 2016. And although they take a fairly aggressive stance on treating gout the moment that we see a flare in the presence of hyperuricemia, they have made no specific mention as to whether we should be treating asymptomatic hyperuricemia. The next guideline is the BSR guideline from the following year. This guideline replaced a previous gout guideline and took a more aggressive stance with a target of 300 micromoles or less in patients with confirmed gout. But once again, no mention of treatment of asymptomatic hyperuricemia. And the final guideline I'm going to mention is the 2020 guideline from the ACR. Now, this is the only guideline that does make any mention of asymptomatic hyperuricemia, with their cutoff of more than 6.8, which is a slightly more aggressive or higher level than my colleague suggested it to, I think, 6.5, if I recall correctly. But again, they mention specifically in this guideline that we should not go ahead and treat asymptomatic hyperuricemia with urate-lowering therapies. So where does the background of even discussing this come in? We have some data from cohort studies. This is a cohort study of 2,046 patients that was nearly 15 years in duration, so some 31,147 patient years. And this was looking at a far more elevated serum uric acid of 9 milligram or 535 micromoles per liter. And even in those patients with extremely high levels of uric acid, only around 22% went on to get gout. Maybe there was a little bit more hypertensive disease, but of course, these studies are more prone to confounding. So the ACR's take on this in particular was, given that this rate of 20% was present, you'd need to treat 24 people with hyperuricemia for a duration of 3 years before you prevented a single gout flare. Impact on comorbidities. So there is obviously some association about comorbidities. We all know that gout and hyperlipidemia and hypertension, obesity, they are all linked. But there's a bit of a concern here about reverse causality rather than saying that the hyperuricemia is driving these comorbidities. So I will look at the one guideline that is out there that does talk about treatment of asymptomatic hyperuricemia, which is the Japanese guideline. Now, even within this guideline, where they mention the treatment of asymptomatic hyperuricemia in the context of kidney disease, even they acknowledge that the quality of the evidence is moderate at best, more commonly weak or very weak. Much like other Japanese inventions, like their fantastically technological toilet seats, which are heated, this is a rather comforting but not necessary intervention for the whole world. Thank you very much. Evidence to support hyperuricemia. Let's just put myself in my opponent's, learned opponent's shoes for a second and think if I was going to try and look at the evidence. I had a few trials where I thought stuck out. For example, this trial, which showed a small change in EGFR, but there's only 90-odd people in this trial, 45 in the treatment arm and 48 in the placebo arm, and the follow-up duration was 6 months, so hardly a trial that we want to make major changes in such a common abnormal finding in the lab. This second trial had a slightly larger number of patients, and I do mean slightly larger, with 113 patients followed up for 24 months. They made some various claims about improvements in CKD and ACS, but with such a small number of patients over such a short duration, it's not really credible to, as I say, make these kind of widespread changes across the population. In refuting this, we have evidence from the Feather trial. Now, this had a healthier 443 patients with CKD over a 108-week follow-up, and they found that there was no real mitigation in the EGFR in these patients. What about the CKD Fix trial with a number of 369 patients with CKD 3 or 4, again over a 2-year duration, and no EGFR changes were noted? And finally, the Pearl trial, 267 patients with type 1 diabetes followed up over a 3-year period with no real benefits in the type 1 diabetes control or renal function. So let's look at a little bit more evidence just to solidify my case in the fact that there is no benefit here. There's a meta-analysis of 23 randomized controlled trials, and overall they mentioned some composite improvements in EGFR. Well, what does this actually mean to our patients? If we're improving their EGFR likely over the course of multiple years of treating something asymptomatic, are we really going to be leading them to any improvements in longevity or quality of life? And this editorial, slightly earlier, points out really, considering the lack of good randomized control trial evidence, it is rather presumptive at best to consider intervention in these patients for CKD. In essence, at best, and this is as someone who's quite used to doing this back home in the UK, it's asking everyone here in the Emirates to carry an umbrella just in case it might rain one day. Sure, you may get some benefit, but realistically, most of us are just going to be weighed down by it. So overall, I think there is no reliable all-cause mortality data, cardiovascular data, CKD data, with retrospective studies that do suggest this being more prone to confounding, and largely all of the major guidelines being in favor of not having pharmacological intervention. So with that, I open my case for why there's no real benefit, and I hand over to my learned colleague.
Not my opponent, it's my partner. Okay, he said, well, if you see it's going to rain, you have to take an umbrella. No, it's not like that. If the day is cloudy and it's a rainy season, and I'm going out, I'll take an umbrella. So, well, now I'm going to talk to you about, evidence of relation of uric acid to morbidities, CKD and cardiovascular disease. Yeah, thank you very much. Yeah.
Don't close it better.
Don't close it. Okay.
Sure.
Yeah, I'll just go. Yeah. Well, the interplay of CKD and is very complex. That's why, we had, conflict in interpreting results. In vitro studies as well as animal studies support the role of uric acid in glomerular and pleural interstitial damage. I'm going to admit, however, the expectation of uric acid lowering are inconsistent. A lot of studies have shown that, hyper-uracaemia, asymptomatic, has an increased risk of developing CKD among those with CKD and those without CKD, even in the general population. If your uric acid is high, you are more liable to get chronic kidney disease and cardiovascular disease. And if you have got CKD, the decline will be more fast, but if you have got hyper-uracaemia. And I hope I'm going to show you some evidence for that. Well, this is the mechanism which I think I showed you before about how uric acid affects kidneys and hypertension. Okay. This is a study in peritoneal dialysis patients. They have hyper-uracaemia. It was found that, they have higher mortality. So hyper-uracaemia was, at least I will take that to associate with hypermortality in BD patients. And I'm happy to tell you there is a J curve about hyper-uracaemia, but very low uric acid. You are more liable to die. If you got high uric acid, you are more liable to die. Maybe the hypouricemia is due to malnutrition, which is a major cause of death in those patients with CKD and on dialysis. Again, those are different things, so I'm just going to skip. Well, this is a Swedish renal registry chronic kidney disease. It says uric acid is not associated with the rate of decline in renal GFR or subrenal disease. It says 3, 4, or 5 CKD. So advanced CKD, if you start early treating them, stage 1 and 2, you could get benefits. But here they spoke about later stages, 3, 4, and 5. What about patients with transplant? In patients with transplant, there is high prevalence of hyperuricemia and gout, especially if they are in calcium urine inhibitors, especially cyclosporine. Okay. So 90 to 95% of those patients without immunosuppression with cyclosporine will have hyperuricemia and gout. And if you have them on cyclosporine, that figure will go up to 30 to 84%, and gout prevalence increases in those patients, especially if they are on cyclosporine. There's another study in transplant patients. Patients with hyperuricemia here. They have shorter survival rates compared to patients with normal uric acid level. So at least there is a association between uric acid level and survival in renal transplant patients. Those are multiple observational studies. I'm just going to show you the conclusion. In the general population, higher levels of serum uric acid compared greater risk for incident CKD and end-stage renal failure. The risk appears to affect females more than male. And this is shown here. Yeah, it's 3 times in males and 9 times in females. Long-term follow-up of non-CKD individuals showed an increased development of CKD with hyper-uracaemia. We say C5 CKD. Hyperuricemia is a risk factor for all-cause mortality and cardiovascular disease, but not in renal resistance cerebral. And if you remember, the Swedish research, it said the same thing. Well, other observational studies in CKD, and I will just read you the conclusion. In the CKD patient, there appears to be no correlation between CKD progression and cervical hyperuricemia was associated with endothelial dysfunction and mortality. And this is about late stage CKD, stage 3, 4, and 5. I think I'm going to stop here and then hand it to him, and then I will come and tell you about the studies with interventions, with urate lowering medications.
My colleague has presented some rather unique cases, I feel. We're talking here about asymptomatic hyperuricemia and not necessarily post-transplant patients who perhaps have quite a very unique position. And the data that's been presented, I will grant you, there is definitely observational association data, but I come back to my earlier point that we do not necessarily know that this is a causative issue. And there were plenty of confounders and reverse causality to consider in these long, distant retrospective studies. So are you going to put to you that despite there not being a great deal of benefit in going ahead and treating, we actually do have a considerable degree of harm? Okay, so allopurinol hypersensitivity may not be something that we see in every single one of our patients, but then we were never considering putting allopurinol on the script for every single patient with asymptomatic hyperuricemia. And even when we're treating a small number, at most, say 20% of these patients who've gone on to develop gout, we still encounter significant rashes in a small number of patients, gout flares, even when we're trying to titrate this more carefully. And if we're going to start putting this into a widespread use in the same way perhaps we're using statins or antihypertensives, we're probably going to end up with some fatalities. Can we really justify that we're going to have saved anyone's life or even prolonged anyone's life for the fatalities that may arise from the harms of hypersensitivity reactions? And have we forgotten the CARE trial and the data on congestive cardiac disease and use of febuxostat? Again, these patients we know have coexisting comorbidities, of which heart failure may well be one of them. And we're going to be treating them for this indice, which we have no real knowledge is going to shorten their life with a drug that we have data may well worsen their cardiac outcomes. There are also other interactions, and we've talked about our patients may be transplant patients, but I'm sure we don't want to be combining allopurinol and azathioprine, for example, if we were to do that for our transplant population. I accept it might not be a common post-transplant drug, but still. And then if we want to reduce the harms, we're going to have to do HLA-B testing for these patients, which is not exactly cheap and certainly not universally available. I will come back to this issue here, which is if anyone in the audience has a 100% compliance rate for their gout patients, I would invite them to come up and give us a lecture on how they've managed to achieve that. When our patients come in with exquisitely painful, deforming joints and tophi, and we are there not only saying, do you want to have this happen again? Would you also like to have a higher cardiovascular association? Because I think it's reasonable to use hyperuricemia and its associations when we're persuading gout patients to take the medications. And even then, we know that their adherence is pretty poor, with only around half taking it just as little as a year later. And there's pill fatigue, there's polypharmacy, there's anxiety that we're going to be inducing in these patients taking medications they don't know the benefit for. And the opportunity cost. This is a lot of money we're going to be spending, especially as we're going to add in HLA testing. And really, should we not be spending that money in a more practical way? So I'm going to suggest really that the harms here are significant, and the practical realities of trying to persuade people with a condition that doesn't cause them any bother at a day-to-day basis is going to be hard to sell. It's hard enough to sell taking antihypertensives and lipid-lowering medications when we've got pretty strong and reliable data that will reduce their mortality. So we should do what we are doing, which is to give lifestyle advice and interventions that are low risk and clearly evidence-based. We can suggest weight loss, and we've heard at this conference the benefits of GLP-1 drugs. If we're going to spend our money on a pharmacotherapy, perhaps we should be spending our money on this pharmacotherapy. We should make sure our patients have the best blood pressure control and lipid control that is possible, and also adhere to the other significant comorbidities like diabetes. Again, pharmacotherapy where we can easily persuade patients of the benefits outweighing the harms. Dietary modification, we've heard about fructose and the importance of that. Beer, whether that be with or without alcohol, purine-rich foods, and encouraging our patients to exercise, which not only is going to be helpful in terms of glycemic control, the cardiovascular and respiratory health, mood and joint health, all of these benefits that are going to come at a fraction of the costs, and empowering our patients to take charge over their hyperuricemic risk factor and association by saying, well, the ball's in your court. You need to start doing the things to help improve your health before we start taking away their agency and putting them on pharmaceuticals. I will make this out like the beauty premium fallacy. And so we have some pretty good data, and there was a particularly big study of civil servants in the UK showing that the wealthy and high-paid civil servants lived longer. And there was also some fairly decent economic data from the US that suggests that those with a slightly higher than average attractiveness have a 5 to 10% increase on their earnings, and those with a slightly more unfortunate disposition may earn 5 to 10% less. So perhaps if we want people to live longer, we should be initiating cosmetic surgery for all people so that they can benefit from this beauty premium fallacy. I think not, but my case rests here. So I'm going to leave that to my last section for my learned colleague to respond before bringing my points to a close.
Well, from now on, I'm going to speak about, intervention trials. This is allopurinol treatment improves renal function in patients with type 2 diabetes mellitus and asymptomatic hyperuricemia, a 3-year randomized parallel controlled trial. Conclusion: long-term effective control of serum uric acid can decrease urinary albumin excretion, serum creatinine, increase GFR, and makes their kidney protection tests in patients with type 2 diabetes and asymptomatic hyperuricemia. This was a study. One more study, use of allopurinol in slowing progression of renal disease through its ability to lower serum uric acid. We know all those drugs can lower uric acid, but still some of them have shown that they improve eGFR and reduce progression of CKD. Yeah, this is a study which Francis showed you. It's an Indian study. It was a short study, 6 months for a few number of patients, showed that, if you treat those patients, there was a numerical increase in eGFR in patients treated for hyperuricemia. Other intervention studies, so many of them, okay? As he said, most of them were small studies. But the conclusion in the CKD patient treatment with allopurinol 103 mg associated with less progression in CKD and fewer cardiovascular disease. So it can slow progression of CKD, can prevent cardiovascular disease, which are the main killer in patients with CKD. To summarize, hyperuricemia causes is the cause of consequence, and he was absolutely right, okay? It's an association or it's a cause. It's just a marker or it's a risk factor. Risk factors are those when you treat, you reduce events. Markers are there. If you treat them as well, they don't change. And we had this discussion a long time before imperfinuria and CKD. Is it just a marker or is it a risk factor? And it was proved later on to be a risk factor. But he showed us guidelines, and I agree with him. Most of the guidelines will say don't treat asymptomatic hyperuricemia. Can you agree with kidney guidelines? ULAR, ACR. Okay. Again, this is ACR. Australian and New Zealand guidelines say the same thing. This is a paper from a group, uric acid and CKD. Had the jury come to the verdict, and I think you'll be the jury at the end. I'm not claiming you came to the verdict, but what they say, we believe that the inconsistency on the results from available meta-analysis is mainly due to inadequate sample size, short follow-up times, and heterogeneity. CKD has a very heterogeneous disease. It has so many co-founders, hypertension, diabetes, hyperuricemia, other things. So to dissect each of those in a study is very difficult. And that's why, we didn't reach, a conclusion. It's a cause or it's an association. To treat or not to treat asymptomatic hypertension. This was a study from Saudi Arabia. This was a rheumatologist who did, a survey. They had a questionnaire for orthopedicians, rheumatologists, internal physicians. The conclusion was that the drug showed that the doctors in Mecca region depend on the serum uric acid levels to decide when to stop the treatment, not abiding by the international guidelines. So most of the doctors will treat, and have seen that, Patient go to some people, a uric acid of 7.4, they will start treatment. And this is where Francis was alluding to, are we over-treating lab values instead of patients? We should be treating patients. Those are Chinese guidelines. The Chinese guidelines say, well, you have to treat. If your uric acid is high, you have to above 9, significant comorbidities, you have to treat. Who are the high-risk patient profiles? Presently high serum uric acid levels, uric acid above 10 to 12. Some people take 10 as the cut point, some people take 12, some people take 13. The strong family history and significant comorbidities. Those are the patients who are at risk, you may think of treating them. When you treat your patient, you have to have a shared clinical decision. You have to discuss with your patient, bringing those side effects of those medications. Most of those medications, except the allopurinol, is very cheap. So it's not cost, it will be cost effective. But it has this rare side effect, hypersensitivity. You have to discuss with your patient and tell them what you're saying and come to a decision with them. And this is another study which said, well, the question should not be, shall we treat or no? It should be, when is the time to start treatment? And for that, the argument for treatment is potential benefits of urate-lowering therapy, slows CKD progression, reduce cardiovascular risk, both the randomized controlled trials and cohort studies. This is a meta-analysis. We showed, it improves GFR, treatment safety in CKD in low dose, especially allopurinol. If you speak at the 50%, truly it has some cardiovascular, warning, but it can again improve your outcomes. What are my current recommendations for treatment? A serum uric acid above 10 to 12 milligrams, patient risk factor for gout or renal disease, hereditary hyperuricemia, and as Dr. Francis was saying, you have always to start with lifestyle modification, including weight reduction by adjustment, dietary volume, composition of volume and composition of diet. Avoidance of alcohol and sugar-sweetened beverages and regular exercise to reduce weight. We emphasize that the relied patient care suggests need for more than clinical trials. You have seen, most of the trials were small, and they could not dissect exactly uric acid or cause or association. So I see youngster here, they could do those trials, A lot of patients with CKD, a lot of patients with hyperuricemia, you could do those trials and tell us. I just brought this slide, this is my last slide. This is an Italian study, and you'll be surprised to see this. The cutoff for myocardial infarction in uric acid of 5.7, just below even, the level we think is normal. The cutoff for cardiovascular events, 5.34. The cutoff for stroke, 4.79. If you are above those levels, you are more prone to those things. Cardiovascular mortality, 5.6. Older adults, 4.8. So I hope I gave a case for treatment. I know the guidelines say, they don't say that, but my feeling is that the future will change the guidelines as well. Thank you very much for listening.
Okay, so we spoke about the hyper-uracaemia. So I'm going to bring this to a close relatively quickly. And I'm going to just come back to some principles on medical ethics, upon which we all obviously practice, to summarize the main reasons why I don't think a blanket approach, but the treatment of asymptomatic hyperuricemia exists. Beneficence, we have seen that most of the trial data is tenuous benefit at best, and these are tending to be from the shorter, smaller number trials, with larger scale trials not really showing much benefit, and the real concerns arising from large scale cohort studies where we shouldn't really be then making a decision on an intervention like urate lowering therapies. In terms of the harm, we are going to cause patients harm from drug interactions, from pill fatigue, from hypersensitivity, from just having to take another medicine and spend another however many dirhams it costs to get their scripts refilled every month. And so I think there's harms that we should be avoiding here. From a principle of justice, I think we could spend the money far better by having better access to dietary advice, better access to lifestyle interventions, and to treat the other comorbidities where we have a much better evidence base for interventions. And autonomy, last but not least, do our patients really want to be taking yet another pill for some tenuous association? I don't think they do. Now, practical clinical conclusions, and this is my last slide. The reality is that medicine is not black and white. It is grey, and that is what makes it so enjoyable, in my opinion at least. And I particularly like rheumatology because you can get 3 rheumatologists together and obtain at least 5 different opinions. So I think my learned colleague has presented a valiant effort in a much harder position to argue, but there are some very significant points that I think I need to concede here, which is that we don't practice a one-size-fits-all. Yes, I've taken the position, and luckily I also believe in the position, that a blanket treatment of asymptomatic hyperuricemia is not the right thing to do. But does that mean I think that any patient treated for non-gout hyperuricemia has had the wrong treatment initiated? No, I do not. And clearly we've had patients where there is significant renal comorbidities, or highly motivated people who are already optimizing their exercise and diet and really want to have a pharmaceutical to improve eGFR, even though the evidence base is still early on. I think these patients should not be prevented from being treated. And in some situations, we do need to think about considering urate lowering therapies. But again, we treat our patients and we do not treat numbers. So with that, I close and thank you all very much for your attention. These are my references. Thank you.